Welcome back, listeners, and welcome back, Patches. My guest today is Patches Seeley. We've talked before, and if you did not hear that episode, please go back and listen to that. She shared her experiences with healthcare professionals diverting at facilities where she was the clinical nurse manager, and she talked about the impact that that had on her staff, and she really provided some great insight. So thank you for that, Patches, and welcome back.
Glad to be back. Thank you.
Today, we're going to talk about the intersection between serious safety events and diversion case reviews. And I think what I'm going to do is start with the definition of an HRO. We touched on that a little bit in our first podcast, but we didn't really define it for those that are unfamiliar with it. You gave us a few insights on it. Deference to a more experienced person, I think, was one thing that you said, which I think was great. But let's start with that. So let's define a high reliability organization.
You bet. When I think about high reliability, the best place to start your research is the airline industry. That's really where the concept of high reliability came into the marketplace. And how do we make air travel airtight? How do we prevent, negative outcomes for our airline travelers? And what they've studied, deeply studied, failures and failure points in various policies, procedures, culture inside of the airline industry, and set, I would say, a fairly exhaustive list of ways to prevent errors and to hardwire safety tools in their workforce. And it really does have to be the entire workforce for an organization to become highly reliable. And that means that we can count on them, first to do no harm. Don't hurt me, don't harm me, be nice to me. That's what most people want, right? And so the airline industry really did begin to adopt high reliability principles, and that transitioned into healthcare as we began to, in the industry, become more aware of the amount of medical errors that patients face when they're in our healthcare system. So something had to be done, and many organizations have adopted high reliability principles. So a highly reliable organization is one you basically can depend on to keep you safe, and that is valued by all levels of the organization, and that even in a highly complex, highly stressed organization or situation, that the disciplines of those practices will be carried out and will yield greater safety for our patients.
Yeah, and I like that, hardwiring it, right? I mean, we're all prone to human error. So the more that we rely on the human to do something, the more chance, I guess, we have of something going wrong. But that hardwiring, which is something that we talk about a lot in the pharmacy when it comes to, let's just say order entry. There was, I'm trying to remember back, there was a medication error that I was reviewing in my role as med safety officer. And most medication errors don't harm anybody. We can recover from it pretty quickly. And most people, not even the clinicians, as you had said when we talked earlier, realize sometimes that it even happened. But this one was caught, and this one was filed as an error. And so going in to review it, it was a situation where the dose had to be changed, for the frequency had to be changed for somebody, I think it was with decreased renal function, maybe. And this was a med that was known that you got to make an adjustment, but the frequency was already hardwired in to the EHR for order entry. So it pop up, let's say, every 8 hours. That was just hardwired. Which is not a good idea for a med that needs to be adjusted. And so it may not be Q8 hours, even though that's the standard, right? If somebody had good renal failure. And so that was the problem. And, you could tell that the pharmacist knew that it needed to be adjusted because they added it to their notes. So, renal function changed to once daily dosing, or recommend, whatever it was, but yet in the order entry process, they missed that Q8 needed to be changed to once a day. And so that was a case of, wait a minute, you hardwired in the order frequency, but you shouldn't do that for a med that requires adjustment. You need to make the person put that in because they missed it. So it almost seems counterintuitive in terms of, well, you said to hardwire it, yeah, but not on a med that is regularly adjusted. And so that was a change that then went through the IT department. We need to take this Q8 hours out.
You're saying something that's resonating with me, in that when we first opened this discussion, we were thinking of human processes that need to be highly reliable. But the way we build our tools around our humans, right? We have to consider high reliability principles as well there. And that although maybe 80% of patients would need this particular dosing schedule, we need to account for, in the way our tech is built, that we aren't forgetting about what that other 20% might need, for example. And so as we develop new tools around the clinical, in the clinical arena, we have to be thinking about, is our tech being built and designed with high reliability principles in mind as well, and not become over reliant on the technology, but to make sure that we are still using our human factors tools to mitigate risk for our patients. So thank you for saying that, and I think that will should shape all of our high reliability conversations.
Yeah. So from a diversion mitigation perspective, do you see parallel processes for like serious safety events and suspected diversion review? Do you see those dovetailing in any way in an HRO?
Yeah, I'm glad that you asked that. Putting on kind of a clinical informaticist hat, which is one that I wore for a period of time. If you think about the beginning of the detection of a diversion circumstance, the reports that you receive, and how you receive those, and integrating that into your daily practices, and integrating a certain discipline around how you review those reports each time. The preoccupation with failure, that is a huge concept in high reliability, is that organizations, individuals, units, departments, areas of service all have to be preoccupied with the possibility of failure. And in the case of diversion, we have to be preoccupied with that as a possibility. So when we receive that report, we need to be preoccupied with the fact that we may have a diversion situation as we review those reports. And so I think the concept of preoccupation with failure is pretty critical to avoid. So that's one intersection. And that's really at the beginning of the process of the detection of the potential for drug diversion. Whenever we get to the place of maybe interviewing someone, how we conduct those interviews, establishing a posture of empathy, establishing a posture of, we're not looking to find failure in you, we are looking to find facts. And let's talk that through in such a way that we find factual information as we investigate a case. And then the thing that I see as a glaring miss is that oftentimes when we investigate serious safety events, we don't ask about impairment. Is there a possibility that any of the clinicians involved in the care of this patient may have been impaired? And does any of this behavior suggest, and then does any of the technology, the reports, the connection between MAR, med distribution system, diversion software, is any of this maybe pointing our eyes? We need that filter. We need the possibility of impairment as we discuss serious safety events. And as many serious safety events as I investigated in my time in clinical executive leadership, the conversation never came up. Could these individuals be impaired? And so I think that's a very good point.
Yeah, I think it's a big miss. And I am a huge proponent of, well, education throughout the entire facility, of course, as to what diversion is. Many people just they don't think about it. They don't understand. They don't think that it happens in a healthcare environment. I mean, why would a licensed healthcare professional put their patients at risk like that? But we're human, and these things happen. So people don't think about it. And I am constantly amazed at conversations that I have with people that have this, moment. And it's like, well, I don't know. I didn't think about that. So I am a huge proponent of, you have to engage your risk department in this education piece of it, because there are going to be things that I don't know that the risk department does know, because we're just not privy to that, right? Especially if it involves a physician. And that's the whole peer review behind the curtain thing. But somebody in your organization that is privy to every single event needs to be aware that diversion or just impairment could be a factor. And so they need to then be your partner to say, hey, they don't have to tell you, oh, so-and-so was involved in a wrong site surgery, but they need to say, can you take a look at the reports for so-and-so and just let me know if anything, we had an event and I just want to make sure nothing else is pointing to anything. So yeah, risk 100%. And also patient experience or patient complaints, or, that hotline that patients can call and just do kind of this generic complaint. I'm very unhappy with this and this happened. That person needs to be aware as well, because that could be a factor in
Surface.
those.
You bet. I think in the last time we were together, Terri, we talked about linking arms, pharmacy and nursing, right? As we develop, as we look at diversion cases. You just talked about the linking of arms with multiple departments. There is safety science, and our safety science colleagues, our clinical quality colleagues who are already going to be involved in investigating errors and incidences. That's who we link arms with in circumstances like this, to really help us develop the concept of impairment as a filter. And and using that possibility to investigate, to additionally, it may not be the full focus of the investigation, right? But even to ask the question, is there any possibility that any clinicians involved in the care of this patient that resulted in this outcome, do we have a situation of possible impairment? And in most organizations that I've been involved with, the clinical quality team really does have ownership of serious safety event investigation and the processes around those. And using our relationship with pharmacy to look at diversion, I think, is a critical link that we've missed. And then to your point, not all accesses are the same. Now, I don't really know why. There's just as much danger in a physician, a pharmacist, a nurse, a PT, an RT, being impaired. There's risk to the patient either way, but there are certain regulatory and legal boundaries that are different depending on role. But those are accessible. So your processes need to include bringing in those partners so that you can ask that question and get a reasonable response. But we aren't even asking the question. So.
Right. And not from your experience, I'm going to guess, not all organizations have that HRO mindset, even though you think that would be, they would.
Yeah, I have the good fortune of having experience in a large healthcare system where the commitment to safety and patient outcomes was, mission integrated. It was funded, the ability to complete a great deal of training for becoming a high reliability organization. But I will tell you, it's very complex, very difficult, and really is culture dependent. You have to get the right high reliability organization culture into your organization, and that takes an immense amount of leadership will and organizational will, way beyond training. So I had the good fortune of being part of an organization that did training in that space, and I became a trainer inside that organization, and for high reliability. And I saw conversations slow down in many ways, because as I'm on the phone with you and we're having a discussion that may involve a number and a decimal place, that I had to make sure that you heard me correctly, Terri, before I went on and carried on that task. That read back, repeat back, small interactions like that can mean big outcomes for the patient if it goes wrong, right?
Yeah.
But each of those increments of time, is a different way in which clinicians, non-clinicians, anyone, spend more time. Sometimes it takes a little more time to do the right thing.
Right, right. And I guess, I mean, if your organization, for anybody listening that is not an HRO organization, that doesn't mean that you as an individual couldn't implement what's possible within your sphere, right? So having that slower conversation, not assuming something, asking somebody to expand a little bit on the order or the conversation, just to clarify, I guess listen to your gut, right? If something seems a little off or it's moving a little too fast, or, ask that person to slow down or
Yeah.
to re-explain. Of course they might get irritated because,
Well, and there are two, I would say, high reliability principles that come up as you're talking about that. One is having a questioning attitude.
yeah,
When something seems amiss, have a questioning attitude. I mean, that's a skill I take forth even in my personal life, right? Because something here does not, my gut, I think you used the term gut, like something
yep,
doesn't feel right about this situation. Well, there's a reason that instinct develops, right?
right.
And
Hmm.
so there is value in pausing and really looking around you at all of the possible failures for this patient. And the other one that you described is how you interact with someone when you're trying to slow the line, right? And it's called ARCC. And ask the question: should we be both validating that this is the right dose for this, for this medication? And then if you continue to get pushback, I recommend that we make sure we analyze this patient order correctly. And then, the next C is about potentially the chain of command, all the way up to the chain of
Mm.
command. I'm not going to go forward until we validate that this order is accurate. That
Mhm.
keeps the process highly reliable. And everybody in the room has to agree that sometimes I may get someone who wants to slow the process, slow the line, in order to get this done accurately for the patient. So there has to be organizational will and organizational desire, support from leadership, and I would say mirroring and being an example of that has to happen from all levels of the
Yeah.
organization. So
Yeah, no, that's good. Yeah, it's happened to me before. Fortunately, nothing with a patient safety type of an issue. It's probably more of a, should I say this? Should I send this email? Should I go direct to this person? Right. And my gut's telling me one thing and I don't listen to it. And
yeah,
then it comes back to bite me. I'm like, man, I wish I had listened to my instinct. So you're right. We definitely have to. If something feels wrong, we need to pursue that, and certainly when it comes to a safety risk. And it also, asking the questions. I always tout that every facility with a diversion program needs a champion, and that champion is the person that keeps things at the forefront, asks those questions, and that is the person that connects
yeah,
with all of the clinical nurse managers, as we talked about in our last podcast, but also risk.
yeah,
Take that time to educate all of the different departments to what diversion is and why you need to keep it top of mind, if anything if anything happens. I think the most unusual way that I was ever alerted of a possible diversion actually came from the billing department.
Wow.
And they saw, I don't even remember what it was. I don't remember what drug or what the situation was, but it had something to do with a medication that was billed on this patient. And I don't know what alerted them. I don't know if it was a duplicate. I wish I could remember the details, but
Yeah.
it was the billing department and they didn't even know what they were onto. They
Yeah.
just was like, this is kind of weird.
Right.
And so they called the pharmacy department. And so then I happened to be engaged in that conversation. And I'm like, yeah, that is kind of weird.
Yeah.
And that led down a whole different path. It had nothing, you know, I mean, yeah, fraudulent billing, but that's what they were focused on, right? And
Yeah.
then it was like, oh, whoa, we have an even bigger problem here. But that
That's
was an
great.
aha moment for me.
I bet it was. And that billing agent or billing professional had a questioning attitude. I mean,
Yes.
they were employing an HRO principal. They were
Yeah.
preoccupied with failure. Something is not right here. I've got to do something. I'm not exactly sure what this is, but something isn't quite right. And they didn't deny that gut. And they said, well, it's about a medication. Let's call the pharmacy. That's a start, right? To honor that gut instinct that you're having. And so they may not have known they were employing a high reliability principle. But in that tell us even more about educate all departments. You know, assume everybody knows nothing, no one knows anything about diversion, and go talk and share that possibility with multiple departments.
Yeah, nobody knows anything and everybody may have a role.
Yeah.
You know,
that
it's just
be a little bit to data integration, or, data points, right? Like using the medication administration system reports, using what's in the EHR. And of course, when I was in clinical management, those two did not talk, right? It was a manual process to pull all of the data elements together. But your billing software has data that might tell a story around clinical activity. So I think sometimes we underestimate maybe where all of the possible data points are that might tell us a story about diversion. What a great, well, not a great experience, but what an interesting, experience. And good for that individual to, that's another thing that happens sometimes is there's an authority gradient. And, oh, well, I'm not sure the physician ordered this correctly, but should I say that? Or I'm just a billing agent. I shouldn't ask the pharmacy about that, or this doesn't seem right, or, wow, am I going to seem, I'm a little afraid maybe to escalate this to a level. If you have to eliminate that authority gradient among your team so that they feel empowered to raise.
Absolutely. Yeah. And it's also, I mean, I don't know. I think the tendency maybe is to just say, well, it's a one-off. I'm just going to ignore it.
Yeah.
But that one-off may lead to really big changes or really big discoveries, even back to that example of the frequency that was, in the electronic piece of, I used to really want to dig into every medication error, because what is the point of having a medication error reduction program if you're not looking for ways to reduce the errors? But, it's labor intensive to look at every single one and like, is there something we can do to hardwire this? Or is it truly just a human error that we just can't control? And it's just one of those things that happened. But if you're asking those questions and take the time to look into even the one-offs, it's amazing sometimes what you can discover.
So Terri, when you were in practice inside of a provider organization, and how many times did you ever get brought into, whenever you were specific to, your work was specific to diversion, brought into a serious safety event or a root cause analysis program, or did organizations that you work for maybe begin to change that a little bit? Or do you validate what I experienced and that we never really even measured the two?
Yeah, it didn't really. So when the first organization that I worked in where I was involved in diversion monitoring, I had no integration into any, other serious safety events or anything like that. The second organization, I was in the position of medication safety officer and ops manager, and I was overseeing the diversion program. So then I was brought in for some things, but it was in that position that I was very proactive with risk, having that conversation is like, look, I know you can't tell me everything that's going on, but I want you to be aware that there might be something going on, and developed that relationship where it even was to the point where I could call them and say, okay, I have been auditing, and it usually was an anesthesia provider, just because, that's what we're really not going to hear about. It's like, look, I've got some numbers on this provider that I'm not quite sure, but I'm going to give you their name. You've got the rest of the information. Do with it what you will. If there's anything else going on with something in the OR that you have heard about. So we did in those cases, and I would hope that, they kept that in mind. Now, did they ever come the other direction and say, hey, we need to look at this? I kind of feel like once maybe they did, but I don't know what became of it, because that is not shared, of course. But it was a nice role to be in, because I did have that larger picture, right? I saw what was happening on the operations side of pharmacy. I saw if the technicians would be like, why do I have to keep refilling this, a non-controlled substance medication, perhaps, that can be used to substitute for or to combat withdrawals? Like, why does this keep running out when it's not really running out, right? But it was an afterthought. Right? I don't care how many times I tried to tell them, let me know if you see, but you're just having a conversation, and then it's like, oh yeah. It's like, really? Like, you should have come to me proactively with this.
Escalation.
Exactly. So it was a constant re-education. If somebody calls and tells you that they opened up the automated dispensing machine and there's a broken vial of, all you have is the ampule or the, and I guess it's kind of wet. It's like, okay, you need to tell me about these things, because that could be a bigger picture. But it is a constant re-education. I don't know. People don't want to go there, I guess. And think about that.
I can't get this phrase out of my head, is the preoccupation with failure. And sensitivity to operations are two, I would say, high reliability principles, but training a workforce to have and I would say training a workforce and building a culture around preoccupation with failure is really tough to do. I mean, there are lots of people in an organization, lots of individuals in an organization. You describing the associate who refills the Pyxis or the Omnicell or whatever your drug delivery tool of choice is, and noticing those strange variations from norm. So same phenomena happens in nursing. We have to recognize the small variation from norm, and then we have to be sensitive to the operation and be sensitive to the fact that for them in that moment, it may not trigger anything, but what escalation processes do we have in place so that those nuances, those small changes from normal policy, procedure, process, whatever, is escalated? Like, they, will they escalate? Do we have those policies and procedures to escalate? Do they escalate? If we have them, doesn't mean anything if there's no culture to do it. Or am I afraid to escalate? Those nuances in a highly reliable organization, it is that preoccupation with failure is got to just be running in the back of everyone's mind. And wow, this is not right. This is not quite usual. I need to escalate this.
Right. And to have one person, you don't know everything else that's happening, but if there's one person that does and something unusual happens and you go to that point person, they can connect the dots of 3, 4, and 5 that also happened, and start to recognize that pattern. But individually, we're just focused on the individual. Oh, that's never happened before. Oh, that's a one-off, or that's kind of weird. And that's that. And then nobody knows about it.
Yeah.
Yeah.
Well, I love the idea of the intersection between serious safety events and
Yeah.
the consideration for diversion, and that's a topic
Yeah.
that's
It
spread.
has to be. It really has to, take some sort of a look at the people involved just to see if there
Mhm.
are other data points that would point to it. I mean, it doesn't even make sense to me that there's a major safety risk and that's not considered.
Yeah, and I wouldn't want, any of our listeners to think, wow, that feels very punitive, like you're just looking for people to fail. And that really is not the intent. It really
Mhm.
is. We're missing an opportunity to help someone
Mhm.
maybe move into a recovery journey. And at the
Yep.
end of the day, the population we have the first responsibility to is the patient, and to
Yep.
uphold our own patient safety, commitments as individual clinicians. We sometimes will have to ask those hard questions. Let's look at the team, and is there any evidence of impairment? But it may seem like a punitive posture, and that's not consistent with HRO principles. We really, in HRO organizations, you really are looking for process failures, system-wide failures, not individual failures. But if we have an impairment case, we have to look at that too as a system failure. You
Yeah,
know, so,
absolutely. Good point. Yeah. And for those that listen to my podcast regularly, I think they know that because I am all about, helping. It's a patient safety, it's a staff safety,
yeah,
and it's a facility liability. But you're right. It sounds punitive. And it is to the extent that you need to remove them from the patient care because it is not safe. But ultimately, as we hear from people who have had a substance use disorder and get into recovery, that that thing that kind of brings it to the head when they get caught, oftentimes it's like, oh, finally, or maybe that's not how they feel then, but as they get into their recovery journey, then it's like, thank you, best thing that ever happened to me, because the outcome is often that person is dead,
yeah, that's
whether on
exactly.
the job or later at home. And so we need to find them as soon as possible. But certainly if it has impacted a patient safety
Mhm.
issue, then we need to stop that immediately. So we
Yeah.
need to find it. Yeah. There was something else I was thinking about and now I've lost my train of thought, but um, yeah, I think there are many positive implications for organizations that do keep a possible substance use disorder at top of mind when it's looking at unexpected events.
Well, I think that something that, the prevalence of substance use disorders, and I wouldn't dare speak to the statistics because I'm uncertain. What I do know is that there is a rise in mental health issues. We see it in
Mhm.
our patient population. We see it in our clinician population. I don't think there's any area of healthcare where we aren't seeing, the rise in virtual mental health. And so it stands to reason that we may see more clinicians, as the microcosm of the larger population, right, struggling with some type of mental illness. And I worked in mental health long enough to know that dual diagnosis is very real, that perhaps you have a mental health diagnosis and that substance use isn't far behind that, because
Yeah,
maybe you're using medications, drugs, alcohol, so forth, a drug of choice, so to speak,
right.
as a coping mechanism. And so I would stand to think that we're maybe more aware of mental health and substance use issues, but we also have an increasing number. So
Mhm.
we really should be putting processes in place that make sure that we're looking at the possibility of impairment when we look at a serious safety event. So,
Yeah, absolutely. And then you add access on top of it if your drug of choice is something that, you have access to.
mhm.
I remembered what it was. Patient interviews. Do you do patient interviews about their care? And, that's where you sometimes learn about bad care that might also indicate some sort of impairment or diversion piece of it. Do you find that they have a larger role in an HRO organization?
Yeah, and most organizations that implement HRO are also deeply valuing patient experience, right? And there is evidence to show that patient rounding is a valuable tool to improve patient experience. And so the discipline of, and in my experience, we have used the clinical manager role or a more senior nurse of the supervisory role to conduct patient rounds, maybe not on 100% of the patients, but some, percentage of patients, with a disciplined interview style, looking to cover all of their experience and conversations about the quality of the care that's being delivered uh, are going to come up, right? If we're doing good active interviewing skills with our patients, then those stories should arise, and it's expected that that follow-up is done on those patients. Trends are evaluated, and follow-up is done on those patient experience interviews. And so, a highly reliable organization is definitely doing that. But I've seen a lot of organizations that maybe aren't considered high reliability or haven't gone through full training, but they still do patient interviews because patient experience is such a critical topic. As patients are consumers; they've already look to see what the quality of your organization is. So we want to make sure they leave with a good experience, rather than a bad meme that never ends, right? Bad press always sticks a little longer than good press.
Yeah. No, but I think, for the organizations out there that are doing patient experience interviews, that is an easy addition to add a few questions if they're not already there, but to educate those that are doing those patient interviews, add the questions that can get to the root of, did you get all the medications that you were supposed to get? And to kind of fine tune it. Sometimes even, if staff are used to seeing people go in and do the interviews, it's easy to then, I think we have a problem with this particular caregiver, to insert some extra interviews that are a little bit more pointed because they're already used to people interviewing. But if you educate those that regularly do those interviews to be kind of pointed about some questions, don't want to scare the patients, but because you're going to learn some things. I've been surprised in the past where there's been perhaps an audit done and some concerns about somebody. And so it's like, okay, now we got to start this full investigation. And then somebody decides to go interview a patient because they haven't been interviewing any patients. And the patient comes out with, oh yeah, my meds never work when Mary's my nurse, and it's like, why didn't the patient come forth with this?
Yeah.
Number one, but number two, nobody's ever asked. And so look what you would have found out had you asked.
Yeah.
So I think that, for the listeners out there that don't work at an HRO organization, it doesn't mean you can't implement some of these things and take some of these things back to your people, engage your risk, engage all of your departments in understanding, even the billing department, and understanding what diversion is, and then getting those patient interviews beefed up a little bit if you're already doing them. And if you're not, then, consider starting some. Start slow, but start some.
That very open-ended question around, tell me about how your medications are working with you, and depending on the answers to this. So conditional logic, if there's an answer that's given this way, well, then you explore a little bit layer. But I think what you're suggesting is use the possibility of impairment as a filter for the types of questions that you might explore with a patient. And again, this, in the spirit of good patient care, that's the spirit of it, right? It's not designed to be punitive or, but just really understanding. And sometimes, you may have a patient who can tell you more of the story than you expect. And you might learn that clinically something is just not working for them, and you need to correct that too.
Absolutely. Yeah, you can learn all kinds of things by talking to patients. I had talking to a patient once. They called me up on the floor because this patient was wanting to do their own insulin with their own reusable needles. And, it's like, Terri, talk some sense into this patient. But in that conversation, I'm looking at their profile, and they had a benzodiazepine on their profile. It was a standard, admission orders, right? And he's like, I don't use that. They asked me, I don't use it. It's like, well, why is this on the order? So nobody was diverting. Nobody was taking advantage of it. He was a little bothered by being asked all the time, but it's a risk for diversion when it's on that profile. So just take it off.
Just take it off. That's right.
Yeah. But those are things that you can
learn.
learn.
Safety risk, and you've solved the patient experience issue, because now you don't have to ask the patient the same questions and burden them as they're trying to heal. Yeah. Well, we got work to do. Yeah. We got a lot of work to do.
We do.
For lifetime.
All right. Yeah. Job security. All right, Patches, thank you very much for your time today. I really appreciate it. I enjoyed the discussion.
Same. Thank you so much. It was great to be here.